Now it's time for our panel of experts featuring patient and physician voices to further discuss better diagnosis and treatment of chronic kidney disease. Please welcome, we've got some great panelists here, Dr. Susan Quaggin, the president of the American Society of Nephrology, which represents more than 21,000 kidney health professionals, Dr. Elena Rios, CEO and president of the National Hispanic Medical Association, representing 50,000 Hispanic physicians in the United States, Kevin Longino, CEO of the National Kidney Foundation and a kidney transplant recipient. We'll get more into that. As also Richard Knight, president of the American Association of Kidney Patients, and he is also a kidney transplant recipient. So we want to hear those stories. Thank you all for joining me. I'm going to start with Susan. Your association has released the United for Kidney Health initiative. Can you tell us a little bit about that?
Sure. Well, thank you very much, and really great to be here and focused on chronic kidney disease. So the United for Kidney Health is a strategic plan that sets the priorities of our society, and it's focused on 4 pillars. One is to intervene earlier, and you've heard a lot about that already today, the importance of diagnosing kidney disease earlier, of transforming transplant, accelerating innovation and increasing patient choice, and achieving equity and eliminating disparities. And I think you've heard that message loud and clear. If we're going to make any impact on this public health crisis in the United States, we really must focus on all of those pillars.
Elena, let me go to you. What about the barriers that are facing the Hispanic community? Has there been progress in that area, and what more needs to be done?
Well, I think one of the biggest barriers, of course, is that the Hispanic community still remain about a third without health insurance across the board. But I have to say, with Medicare and Medicare Advantage, there are a lot more Hispanics. The trend is upward in terms of applying for Medicare, and I think because the elderly do understand the importance of their health. But when it comes to families getting information about high blood pressure and diabetes, which is rampant in the Hispanic community, healthy lifestyles, nutrition, physical activity, all those educational campaigns that are needed are not there in our communities. And I think because we don't have insurance, our country thinks that, well, if you go to the doctor, you'll get information on how to live a healthy lifestyle. But in reality, and I think we found this out with COVID-19 and the pandemic, we really need to put information into our public health infrastructure and in the communities where people live and work and play, which is what Healthy People is all about, right? To have more health information about getting your high blood pressure checked, getting blood pressure checked, getting your sugar checked, so that we can start finding kidney disease earlier. And I think that's one of the biggest barriers, just the information that's not out there in our communities.
Just a quick follow-up on that. What is the effect of the last 2+ years with COVID? Because a lot of people have skipped those preventative steps.
Right. I agree. A lot of people have not gone to, doctors' offices and dentist offices and hospitals all had to close, right, except for the COVID patients. So yes, a lot of people lost their connection with their healthcare providers. I think the other problem with the dialysis centers having more people sick with COVID and having to isolate and not go into the dialysis centers, or dialysis center staff being sick and having to decrease the ability to provide services. So yes, there's been a lot of barriers with the COVID pandemic too, for our chronic kidney disease patients.
Richard, let's hear your personal story of kidney disease and getting a transplant. Can you tell our viewers kind of what that process was like?
Certainly. First of all, I want to say thank you for the invitation to participate in the event today. It's appropriately entitled Kidney Disease Forging Patient-Centered Solution. With respect to my personal story, I've been a CKD patient since 1996, when I was first told that I had protein in my urine, which is clearly a sign of impending kidney failure, which I did not know at the time. Fast forward several years later, I went on dialysis in 2004, stayed there for a couple of years, and was fortunate to be able to get a transplant. And I'm 15 plus years out on my transplant. But I want to emphasize this. My story is not dissimilar to many other patients. And what was discussed by Kevin Bernier in the beginning was something that I suffered from, which was not having the opportunity to have the progression of the disease slowed. When I found out in 1996 that I had chronic kidney disease, and I wasn't even diagnosed with it. I later understood that that's what it was, but it took me 8 years before I went on dialysis. That could have been slowed even further. And so I do want to emphasize, because as president of AAKP, and I represent patients, and that's really what we're about. And our whole organizing principle is about the kidney patient consumer care choice. And I can't get away from that, because we're intelligent consumers. We're like everyone else. We want treatments. And what was discussed earlier, access or inaccess to treatments, is something that we really, really have to focus on. So I'm glad to be able to talk here today. And one last thing I want to emphasize, because I didn't notice, and I think it's important to share it with people. The whole notion of patient-centered solutions really started 50 years ago, as I found out, by patient advocates. A patient advocate from our organization, 1973, led to bipartisan United States Congress, and then President Nixon signing into what we have today, the end-stage renal disease program. That remains the only disease-specific entitlement program in America. So I just want to say that it's important for us to understand our history and remember the patient-centered focus of that. And I wish I had known that sooner, and I might have been better off. But that's why we're here today, to educate folks and to continue to talk about solutions.
Absolutely, absolutely. Kevin, please tell us your transplant story.
Oh, hi. My name's Kevin Longino. My transplant story is not too dissimilar, except I had a good outcome. I went into a primary care physician with headaches that wouldn't go away. I was 39 years old. My blood pressure was off the charts, like 165 over 130. And the primary care physician noticed that I had a kidney disease in my family history and referred me to a nephrologist. And from there, I had a biopsy and found out I had FSGS, or a genetic kidney disease. What I didn't know until I came to the National Kidney Foundation and became a volunteer and now on staff is that this is such an unusual situation that I'm the exception. As someone mentioned earlier, 90% of the people in the country that have kidney disease don't know it. So there's 37 million people with kidney disease in this country estimated, and 90% have yet to be diagnosed. As Tom mentioned early on, it's primary care's burden to really pick this up, because they're the ones dealing with the population. But there's been in the past, there's been a lot of issues and barriers to picking up kidney disease in primary care. And what we're trying to do as an organization and as a community, and people on this call, is to really get primary care empowered to do a better job to picking up those undiagnosed and getting those folks into some sort of treatment program that can delay kidney failure, or even postpone it, or even prevent it.
Kevin, your association has a consumer campaign that's called "Are You the 33%?" Tell us about that. That's and right. How people can utilize that.
Well, it's a great campaign. Thank you for asking about it. It's a campaign where we're trying to let people, particularly communities of color, Hispanic, or folks that were Spanish or English is not their first language, understand that they could be at risk for kidney disease, understand what those risk factors are, diabetes, hypertension, family history, obesity, other things. See themselves in the quiz, take the quiz, find out where their situation is, And then if it looks like that they might be at high risk for kidney disease, we give that patient or that individual materials on how to have a productive and thoughtful conversation with their physician. If they don't have a primary care physician, we help them find one by reaching out to community health centers. And then we do the follow-up with that individual to help them make sure they have the patient education materials and the resources they need to really become an intelligent and thoughtful patient, and someone that can really drive and take control of their kidney health as well as their overall health.
I'm going to go down the line, starting with you, Susan, and if you can give me about a minute or 90 seconds, and I know that's a short amount of time based upon this question, but based upon your experience, all of you have been in this field for years. Susan, what can Congress and the administration do that they're not doing? And it could also include things that are going well.
Okay, yeah, that is a loaded question. I think the foundation has been well laid earlier in the program, that we have an incredible crisis in this country with 37 million Americans living with kidney disease, 90% not knowing it, 1 in 3 at risk. We currently have no recommendations from the USPSTF for screening. That's a U.S. Preventative and Screening Task Force on kidney disease. The last time they looked at it was in 2012. And at that point, they said there was no evidence that screening for kidney disease, even at risk populations, was of benefit. Of course, we know that has changed, and I'm incredibly excited. You're right, I've been in this field a long time. I think we are at a point in nephrology and kidney medicine where we have incredible, powerful new therapies that can slow progression of disease, just as Mr. Knight was talking about earlier on. I mean, drugs that are so powerful that it's sort of shout from the rooftop for the nephrologists in the field, that can slow progression onto dialysis for the average patient of 15 years, and back of the envelope calculations could save 100,000 lives in the US alone in just 2 years, and prevent 250,000 people going on to dialysis or losing a large portion of their kidney function. So the challenge, we know the data, the challenge is implementing this and getting these therapies to the patients who need them, to all patients who need them. So that requires a huge amount of effort, and I'm delighted, we have partnerships with the National Kidney Foundation, American Association of Kidney Patients. I mean, together it has to be the professionals as well as the patients stepping up and advocating for this. So I think Congress can do a lot of things. When we have champions in Congress, amazing things happen. We just saw that Immunosuppressive Drug Act, was passed because of champions, but there's so much more that we need. We heard about telehealth. We need that to be passed. We need access and the pricing of these drugs so that they make it to all patients. So I'm sure I've taken more than 90 seconds. I think I could carry on for hours and hours, but I want to give my other co-panelists an opportunity.
Yes, no, that's totally fair, and you did a great job. Elena, about you, I know you mentioned the uninsured. Obviously, Congress is not with the makeup and the majorities right now. It's not likely to pass any new benefit, but what else do you see that Congress can do? And obviously, this is a bipartisan event. We interviewed a Republican, Brett Guthrie, going to be interviewing Congressman Payne. What do you think that can be done? And obviously, we're in divided government because of the filibuster. So Republicans have to go along with something in order to get it done.
Well, I think given the pandemic and I'm going to say the new buzzword of essential workers, let me say in our society, which to me means a lot of minorities and poor people. But I think if essential workers could be the focus, and knowing that we're going to have continued pandemics, continued importance of healthcare services to keep those people who have to face the worst of the pandemic's impact, is to help them. And I think that it may be a new era for us. And I'll just say it's health equity in a way that does not just focus on one community or another, and looking at health equity programs that can continue to be increased. So we have health equity at CDC for public health and Medicare for our elderly. We have research at NIH and ARC, and all of these agencies all have offices of minority health and health equity, which I think is slowly being considered to be changed to all people in our country that need a little extra help. So I think that, the Surgeon General had a big meeting about hypertension a few years ago. There's no reason why the Surgeon General can have a big meeting about end-stage renal disease and talk about the health equity impact. And I think a lot of that has to do with education, like I mentioned before, that is a bipartisan, very bipartisan to educate our communities to have healthier lifestyles.
Richard, if you had a magical Washington, D.C. Capitol Hill wand, what would happen?
Well, that's a great question, and I want to say this, and I really want to get to the what I believe is to the heart of the matter: access to some of the innovations that are available. We live in a golden age right now. If you have to have CKD, now is the time to have it. Organizations, ourselves, FASN, Dr. Rios' organization, our allies up on Capitol Hill, we're forced to divert time from educating to really advocating. In terms of the magic wand, I think we need to remind the government leaders, health insurance executives, that having a patient-centered worldview should be a constant and not a variable. I just want to emphasize, because I was struck by the numbers that Kevin Bernier mentioned earlier in terms of access, what Dr. Quaggin mentioned in terms of slowing down the progression of the disease. The reality is that sometimes interference comes in the form of limiting formularies, HMO-style gatekeepers, and administrative burdens that patients and doctors have to overcome. So, the diabetic kidney disease, for example, one of the drugs, Corinna, that's been available. I've had patients call me, and we're just having a tremendous time knocking down the barriers by some of the gatekeepers. So a lot of people talk about inequity and disparity, but what's being done about it? I get a little bit frustrated, but we have to continue on. I'm going to say that for our friends and colleagues, join us. We have a patient voice and a patient choice campaign, similar to what NKF has, where we're educating, working with patients and allowing them the opportunity to vote. But I really want to give thanks to those who have helped us. Dr. Quaggin mentioned the possibility of slowing down the progression of chronic kidney disease. Well, I want to call out companies like Express Scripts, CVS, and Cigna Health, who have allowed patients to have access to the products such as Corinna that slows down the progression of chronic kidney disease. However, we have some actors, we hate to name names, but Humana that just ignore the patients. It's unfair, it's unfortunate. Our concerns need to be addressed. Patient-centeredness needs to be real. I am so fortunate to have and participate in discussions like this. But when I have the patients call me and look at what they're going through and they can't get access to something that clearly is available, innovation and research is mute if we can't get it out there to the patients. Mm-hmm. So I encourage my colleagues to do what we can, and thank you for the opportunity to share some of our concerns and talk about solutions.
Kevin, let me go to you quickly. I do want to get to a viewer question, but I know a lot of great ideas have already been mentioned, but what's on your wish list?
My wish list, I think, real quick, I think what Sue said around the U.S. Preventive Task Force is right on. I think since they made their last ruling in 2012, federal government's probably spent $800 billion on chronic kidney disease, where 60% of it's preventative. I think I couldn't agree more with what Richard said. Access is important. We did a focus group study with the primary care 5 years ago, and one of the number one reasons they don't pick up kidney disease in primary care is because they don't have a therapeutic. At least that's what they said 5 years ago. Now they do have a therapeutic, and those drugs are not available to patients. because of insurance, and that's a problem. Lastly, though, I think the biggest issue, or not the biggest issue, a key issue that government could do something about is NIH funding and CDC funding. In the last 5 years, the NIH funding has increased 35%, but for kidney disease or NIDDK, it's only increased 19%. So we're not even, kidney disease is not even keeping up with the growth of NIH, and yet we've already talked about billions and billions of dollars that are spent every year on kidney disease. And then chronic, the CDC's got a surveillance CKD surveillance program. They only spend $3.5 million a year on it. That's million. And that's certainly not enough to deal with the public health crisis and public health issue that is kidney disease. So more spending from the federal government on upstream understanding of the causes and progression of kidney disease.
Yeah, budgets and priorities are key. I do want to get to the audience question that came in from Emily Arson. Let's take a listen and then have maybe one of you dive in, whoever wants to take it.
Hello, my name is Emily Arson. I'm a senior health policy analyst at the United Hospital Fund. My question is, what efforts can be made to explicitly increase equitable access to kidney care, particularly given that the eGFR has historically included race as a variable, which inaccurately mutes kidney function in Black and Brown patients? Thank you.
Anyone want to grab that one?
Sure, maybe I'll jump in. So I think the question is an outstanding one, and I think it emphasizes the importance, again, of patient and healthcare provider partnerships. So community engagement is one if we're ever going to get equity and access in this country. In addition, the comment about the eGFR was an excellent one, and ASN and NKF launched a task force in 2020 recognizing that race is a social construct, not a biologic construct, and has no place in clinical algorithms. And the kidney estimating formula, which is just an estimating formula, used to include it. So the task force reported out with a new equation that is done millions of times in this country that removed race, with the potential, and NKF has taken the lead in implementing this across the country, which will now hopefully improve access and reduce sort of downplaying kidney dysfunction in patients who are of African or who are African American or Black in this country. So that was a big step, but clearly way more issues to go. And in addition, I think just following up on Kevin's point about the funding for research, one of the other recommendations that came out of the task force was we absolutely need more research, better ways to estimate kidney function, and couldn't emphasize enough that NIH funding needs to increase kidney disease and kidney health.
There you go. Anyone else want to weigh in on the question, whether it's funding or anything else, or any kind of closing statement? Because we're just running out of time, but I want to may not have gotten everything you want to say.
Well, I'd just like to add that I want to thank my colleagues for the work that they do in this area. And certainly the issue of inequities and disparities is something that weighs on the minds of all of us. We must do a better job, and I'm going to say that ASN, NKF, Dr. Rios, great partners, but we must include the patients. Patients must have a seat at the table with these policymakers, and we need to understand, we need to do more than just talk about patient-centered. We actually need to engage the patient.
Yep, that's some very good wisdom there. We have run out of time. Great discussion today. I want to thank our panelists, Dr. Susan Quaggin, President of the American Society of Nephrology, Dr. Elena Rios, CEO and President of the National Hispanic Medical Association, Kevin Longino, CEO of the National Kidney Foundation, and Richard Knight, President of the American Association of Kidney Patients. Thank you for joining us. Thank you for telling your personal stories. Very powerful stuff.